All right, everybody. Well, thank you for coming. I guess it's appropriate to say this is our first webinar from the trauma service, which is awesome to have. And we're excited to have Dr. Shurtleff here today. He's going to be talking about hemorrhagic shock and extremity trauma. A couple housekeeping items for everybody. If you could, as usual, much like what we've done with the EMS webinars, if you could make sure your name, first and last, and your license number have made it into the chat, that'll be great. If you have extra people attending with you and you're attending from a fire station or anything, if you could get each person's name and license number in there, that would also be greatly appreciated. If you are joining us from outside the state of Maine and you would like CHs and need a certificate for that, if you could email me, eric.wellman@mainehealth.org. That number should be, that email should be in the chat at this point. That would be great. And we'll take care of getting you a certificate. So I appreciate everyone joining us today, and I'm going to give the floor to Dr. Shurtleff. Dr. Shurtleff.
Hi. Introduce myself a little bit. I am one of the trauma surgeons at Maine Medical Center, Portland, and my administrative role is the EMS liaison, and in that role, the main goal is collaboration with EMS and to work on cooperatively when there are opportunities for improvement. To that end, also to provide feedback. Really, that's one of the main goals of what I do is in real time let you know what's going on with patients that you have questions about after you drop them off with us. Unfortunately, the way our review process works and how busy we are, the actual hard copy documentation for case reviews takes a while to come out. And so I would just like to offer the pathway that if you have a patient that is critically injured that presents to Maine Medical Center Portland that we take care of, and you have questions about how that patient's doing, what injuries were identified, those types of things. If you ask your chief to contact me, and Eric is going to send out emails to all the chiefs. If I haven't already met you, I know I've met several of you, and we've been working together for a couple of years. But I'd like to at some point meet all of you, all of the folks that bring patients here. So at any rate, that would be the flow of information, and the question would come from the crew to the chief to me, and then I can disseminate information back down through the chief. So we're always here to help, and I find that when we do those types of case reviews, it brings up all sorts of interesting learning opportunities for everyone, myself included. So anyway, I love the work. I love working with you all, and so I look forward to hearing from you. So this lecture is an amalgamation of the Maine State protocols, which should be a review for you all, and then also there is some information and techniques borrowed from Advanced Trauma Life Support, which is something that we all learn as interns in surgical residency, and that is developed and put forth by the American College of Surgeons. And then also the Stop the Bleed program, which some of you may be familiar with. And so there are some techniques that maybe are nuanced approaches to what you're already trained to do through the Maine EMS, but I think it's helpful to have some of this background information. So without further ado, let's get into the lecture. So, and I will take questions at the end, only because I'm not as technically savvy to be able to answer things in real time as they're coming up on the chat. Anyway, the learning objectives here, we're going to discuss the management of hemorrhagic shock. We're going to understand the TXA mechanism of action and the evidence for use in polytrauma patients. We're going to know the indications and contraindications for TXA administration. We'll discuss pearls for the use of TXA. And then we'll discuss management of hemorrhage and extremity trauma and management of crush injury and extremity trauma. And just another note, this whole lecture, I put this together. There was an agency that had asked to do a case review and had asked to do review of all these things. And so this lecture was kind of developed for that particular agency, and then has been I've given it in person in several other locations as well, and it tends to bring up a lot of questions and make for interesting discussion. So anyway, here we go. So at the EMT level, the first goal is to ascertain all the sites of bleeding, and those should be controlled directly with pressure first, before a tourniquet, before compressive dressing, before anything, gloved hands and control. And then if you identify a life-threatening extremity injury or life-threatening injury that is not controlled by direct pressure, in that case, I would say applying a tourniquet is indicated. The protocol says consider, but I do think if you have hemorrhage that is not controlled with direct pressure in an extremity, a tourniquet should be applied in all cases. And we'll go into why that's actually supported by evidence. In general, it should be applied proximal to the injury on the affected limb. Um, and the reason for that is that potentially the vascular injury may be more proximal than anticipated based on where the wound is. And then double bone structures, both the forearm and lower leg, can splint arteries, although there is also some nuance to that, and we'll talk about it later on. That's not actually always the case. And then tourniquet should be as tight as possible. That is always the case. No matter where you're applying the tourniquet, for it to work, for it to actually work, it needs to be tight appropriately. It has to be as tight as possible. And then the associated pain, because the functional tourniquet will always be painful. Pain management is always is in general always necessary. We had a long discussion out at a EMS agency last night about using ketamine and IV Tylenol at first in a latter approach to analgesia, because in these folks, if they've lost a significant amount of blood, your ability or the capacity for that patient to tolerate high doses of narcotics is going to be limited. And that can also take a patient that's hovering hemodynamically and put them and make them, push them into a shock state, just based on how the body responds to the vasoplegia that's induced by narcotics. So where possible, initially, as you're laddering up and managing, and this is for all potential hemorrhagic shock patients, it's important to really consider how much narcotic you're going to give and be careful and to step up slowly, because oftentimes a patient that really can't tolerate that then has a pressure of 60 when they hit the trauma bay, and we struggle to catch up, and that can certainly compromise our ability to do an immediate intubation, because if you take a patient that's in shock, that's vasoplegic, needs to be intubated, very often that will precipitate an arrest and an ED thoracotomy. So just a plug for judicious pain as much as possible, and volume expansion, which we'll talk about a little bit prior to arriving at the hospital. So now you've got your pain control, you got your tourniquet on. If the hemorrhage continues application of the tourniquet, revisit it, make sure it's tight. And then if that's the case, a second tourniquet should be applied proximal to the first. And in general, two tourniquets tend to be more effective, just based on experience. And we'll talk about later on about the sort of algorithm that you follow. But again, if you have two tourniquets applied and you still have a hemorrhaging wound, then you move back to manual pressure and using topical hemostatic agents in addition to the tourniquets. And the reason this is so important is that probably the most common cause of life loss due to controllable hemorrhage is extremity trauma in the field. Um, the those are preventable. So the difference there is that if you have injury to the thorax, the abdomen, the pelvis, those potentially are, you cannot really intervene on those. The only thing that you're going to do to approach that is volume expansion, TXA, and diesel, and getting them to the trauma center. But extremity hemorrhage, actually, you are the ones that are going to save the life in the field. It's you all that are doing this. So that's kind of why we take it so seriously and study it so intensively. Um, and so if, however, the hemorrhage is not um, if it won't respond to a tourniquet, if you can't apply a tourniquet to it, an example would be epistaxis or thoracoabdominal trauma. Packing agent in the wound and maintaining pressure is also is the move there, and it's essential for those types of wounds that you apply as much pressure as possible, and that the wounded either extremity or whatever else is on a hard surface, so there's something to counterbalance the pressure that you're applying. Um, if you manage to stop the bleeding after 5 minutes, bandage it appropriately. If not, continue to apply pressure. And we'll talk about a little bit about how to effectively pack a wound so that you've maximized the you've maximized that approach. Treating for shock, managing the airway. There are very rare circumstances where field amputation will be necessary. Those things will be discussed, or they're outside the scope of this lecture. If the patient's already had an amputation and you've managed to get the bleeding controlled, the injured part that has been severed should be cleaned with sterile saline to remove debris and transported with the patient, given the possibility of reimplantation. So it's just in sterile gauze, sterile saline, don't soak, watertight container, plastic bag. That container goes on ice, and and then you bring them here. And that in general probably will be you would have contacted OLMC at that point, and there would be people kind of assisting you with the management of the severed extremity. Um, and if the bleeding cannot be controlled, request a paramedic, especially if the patient's developing signs of shock. And then for the advanced EMT and the paramedic, IV access is important. We know that is actually aside from controlling controllable hemorrhage in the field, IV access is probably the most effective life-saving measure that can be undertaken in the field pre-hospital. It's a bit of a surprise, I imagine, but it turns out that is more effective than cricothyroidotomy. That is more effective than dart placement in tension pneumothorax. That is the number one life-saving measure, is peripheral IVs, particularly if they're done en route and they don't extend the scene time. If the mechanism of injury is consistent with shock, and you're seeing the physical signs of shock with tachycardia, elevated respiratory rate, altered level of consciousness, diaphoresis, transport as soon as efficiently as possible. We know that is really the number one life-saving measure, is rapid transport in hemorrhagic shock in trauma patients. That is the number one life-saving measure. If the cause of shock is not related to hemorrhage, then you'll go down a different pathway. Anaphylaxis, cardiogenic, the chest trauma protocol, which shameless plug for next time, we'll be talking about management of tension pneumothorax. That is a different pathway that we will be reviewing in a month. And if it's medical shock, there is a whole separate protocol for that, which you know more about than I do. So the EMT is again controlling bleeding, and that relies first on identifying all of the potential sources and getting pressure on them first, and then seeing if a tourniquet application can help if it's on an extremity. Airway via the airway algorithm. Oftentimes, these folks will have a patent airway that can be supported and maintained en route without intubation. Again, just the dangers of intubating a unresuscitated patient that can have negative consequences. If the shock is secondary to trauma, mobilize the patient on a spinal board before placing them. You really, in general, trauma patients are not going to be placed in a recumbent position. If has to do with pelvic fracture, then absolutely apply a binder. Those are also, that's really essentially a tourniquet for the pelvis, if you think about it. And when you restore the pelvic ring, when you can reduce that, that will certainly staunch a lot of venous bleeding, which is actually the most common cause of hypotension and pelvic fractures. The whole anterior part of the pelvis fractures and tears basically thousands of venous structures in that area. If the and so then again, if you have hemorrhagic shock, ALS should be present if they're not already there. And then again, en route IV placement is key here. Anything you can do to shorten the patient's scene time is to the good. And then in general, getting some volume expansion started. And so a fluid bolus, according to the following guidelines, PEDS has a 20 milliliter per kilo fluid bolus. For trauma patients, we prefer LR initially, that first liter. Essentially just, get volume in as fast as you can, but in general, don't exceeding 1 liter has been shown to have negative consequences. So you have to think there are other measures we can take to limit the hemorrhage, and so that's TXA, and we'll talk about that in a bit. But maintaining a systolic blood pressure of 90 is critical, I would say, for all trauma patients, but in particular, traumatic brain injury, it's important because we know that mortality increases even if you have a single episode of hypotension and severe traumatic brain injury. Those patients are also very important to oxygenate pre-hospital, but we'll talk about that in a subsequent month when we talk about traumatic brain injury and spinal cord injury. If you do have a patient that has hemorrhagic shock due to trauma, early scene contact is also critical. The sooner we know that patient's coming, the sooner we can mobilize our resources. We can get blood bank mobilized. We can get all of our emergency department instruments open and ready, and we can have an OR mobilized as well. So that's in general the initial approach to hemorrhagic shock. These patients should be monitored, obviously, and then this is basically how we decide to give TXA, this slide here. So either penetrating or blunt trauma or postpartum hemorrhage. Those are your 3 patients where this is life-saving. They must be greater than 16 years of age. They must be hemodynamically unstable as evidenced by tachycardia, hypotension, both. And we'll talk a little bit about the grades of shock and what you'll see. And this is also critical. They have to be less than 3 hours from the injury. So 180 minutes, 3 hours. But then 1 gram is given over 10 minutes. And we get a lot of questions about why 10 minutes. And the main reason for that is you can induce hypotension with TXA. And if you already have a patient that's hemodynamically unstable, that can take somebody from hemodynamic instability to potentially arrest. So that's why the protocol remains 10 minutes. And then we give the second gram when they present to the hospital. But again, this is also you're in contact with one of them. They'll see as you're coming. Um, the contraindications, there are several. So isolated head injury um, is not currently an indication. Um, if a patient has a head injury, on the other hand, in addition to other injuries where they are having hemorrhagic shock, then they should still get the TXA. In other words, critical polytrauma with multiple injuries gets TXA. Head injury alone does not. Um, Patients that are greater than 24 weeks pregnant should not get it. Patients younger than 16. Um, Patients with known hypercoagulable states. Um, and then someone who's farther out than 3 hours. That's really we know that after that we don't get any benefit from TXA. And then patients that are with hemorrhage to GI bleeding, we also know TXA is not helpful. These are the basic classifications of shock. So compensated shock, you can assume 15% or about a liter of blood loss in an adult. Pulse is generally normal, blood pressure is normal, cap refill is normal, respiration is normal. These are folks that initially, when you encounter them, evaluate them, look okay, and then they get to us and they decompensate in an hour or two afterwards. If we don't identify and control a bleeding source that they're harboring, that's not easily identifiable. Mild shock, the first thing you're going to see is the pulse elevates over 100. That's definition of tachycardia. And there you can assume 15 to 30% hemorrhage blood loss. There will be orthostatic changes if you're changing their positions. They may be a little more tachypnic, but overall the blood pressure it may change orthostatically, but otherwise they're above 90. It's class 3 that really gets exciting, and that is actually, the thing that we're looking for. This is true shock where we're employing TXA and volume expansion. So this is greater than 30% blood loss. The pulse is generally elevated over 120, although sometimes older patients on beta blockers, you won't see this, you'll just see the hypotension. But they have a mechanism that's consistent with hemorrhagic shock, or obvious extremity hemorrhage, pelvic fractures, distended belly, or severe mechanism, and that these are the folks that triggers the response. Pressure will be markedly decreased, and likely this is the stage where you start seeing hypotension persistently. They'll be breathing off CO2, so they'll be tachypnic, and they'll be confused because they're not receiving the normal amount of oxygenated blood to the brain, or what their brain's used to. Then severe class 4 shock, they've lost about 2 liters, which is a third, give or take, of their total circulating blood volume. Pulse is markedly elevated. These are the 140s, 150s. They're hypotensive persistently in probably 60 to 80 range. And they are breathing so fast you're worried you got to intubate them, and they're generally lethargic and obtunded. So those are the stages. And in general, for 3 and 4, for moderate and severe, that's where we're giving TXA, we're getting IV access en route, and we're giving volume. And then letting us know they're coming soon so we can get mobilized and ready for you. So here's some pearls for TXA. It's an analog of lysine, which competitively binds plasminogen, which is one of the clotting factors. It interrupts the interactions between fibrin and fibrinolysis. So fibrin is probably the most important, or the most it's factor 1A, but it's probably the most effective at controlling hemorrhage. It's like the final common pathway. And we actually in the OR use a a product called Everest, which has fibrin powder coating it, and we can stop the liver from bleeding and the spleen from bleeding if it's just on the surface with this patch alone. In fact, I had a grade 1 spleen in addition to a whole bunch of other injuries that I was dealing with a couple of days ago, and we were able to control the spleen itself with the fibrin sealant patch. So fibrin is critical, and so in the normal physiology, um, there will be there'll be an enzyme that breaks down fibrin. So we form clot and then we dissolve it. Like the blood is always in a constant state of flux between forming clot and resorbing clot. And so TXA disrupts the ability of the clotting cascade to do that. And so that's what maintains blood clot and potentially can attenuate ongoing life-threatening hemorrhage. So patients in either blunt or penetrating trauma are really the patients we've studied the most with this, and they benefit the most. Should be given as soon as possible. We know that the effects attenuate over time. Outside 3 hours, it's not helpful at all. In fact, may have harmful side effects. But the sooner to the injury you give it, the more effective it is. So when you're talking with the OLMC, knowing the time of the injury is critical. Be aware, and then let everyone know that you gave TXA. Give the 1 gram dose over 10 minutes, and then flag the IV line so that we know which one it's running through if you're here in under 10, or if you start the transfusion or the infusion within 10 minutes of arrival. Also, if you do know that they're anticoagulated, please let us know that, and we can work out if they should get it or not. Most they can have additive thrombotic effects, and that's why there are certain anticoagulants where maybe it's not going to be of benefit. But we can talk about that on a case-by-case basis. There's few adverse effects overall from TXA. We used to think maybe it caused more strokes or increased DVT and pulmonary embolism, but in fact, when we revisited that data, that was not the case. But the reason why we don't go faster than 10 minutes again is because it can cause hypotension and take a patient that's already unstable and make them more so. Additional pearls, it is not indicated for GI bleeding. And that's based on the fact that we tried it and it didn't work. And then those folks, for whatever reason, had a higher risk of venous thromboembolism. And it's still controversial in isolated head injury. And so as far as, and we haven't revised this since 2021, went back and looked at the new protocols, and it still is a contraindication. However, if they have other injuries that you think are causing hemorrhagic shock, then that patient should still get the TXA. So it's just a kind of a nuance. If it's isolated, no. If the head injury is with other injuries, then yes. And so I want to present a little bit of the evidence behind this, just to kind of add a little more depth to the whole discussion. So this was systematic review of the impact of pre-hospital TXA on mortality. Excuse me, and this was published in 2021 in the Journal of Trauma and Acute Care Surgery, which is our kind of Bible in trauma surgery. It's a monthly journal that really is kind of at the forefront of everything that we do. And trauma is commonest cause of death, disability globally, 10% of worldwide mortality, so not an insignificant cause of death. And 4 of 10 in-hospital deaths after injury are caused by trauma-associated hemorrhage. So, the earlier the intervention you can make, the better. And half of trauma patients that eventually die of their injuries will do so unseen before arrival to the hospital. So really, it is a game of seconds. with severe injury. Acute traumatic coagulopathy is a clinical syndrome that occurs immediately after major tissue injury, and that's a global throughout the body. When the body's in profound shock, we no longer can form blood clot effectively, and so things that would be a minor bleed if they were isolated globally, now it's you have hemorrhage everywhere. And increased fibrinolytic activity. So we were talking about fibrinolysis and how lysine blocks that. That's where TXA comes in. It will quell this increased fibrinolysis within the body globally, which is why it works. So the CRASH-2 trial, which is really the one that we all still quote, they found empiric use of TXA for treatment with those with hemorrhage or at risk of bleeding improves survival when administered within 3 hours of injury. The burden of hemorrhagic deaths from trauma occur within the first 2 to 3 hours after injury. So that's really where this is effective. That's really where you all are saving lives. Pre-hospital interventions for rapid control of hemorrhage and preemptive correction of ATC are therefore likely to have the greatest impact at reducing mortality. So it's everything. It's compression, it's tourniquets, it's TXA, it's judicious volume expansion, judicious analgesia. Those are the things that save these patients in the field. Earlier administration of TXA appears to confer greater survival benefit. It's kind of a restatement of what I was saying before. Particularly if you're within 90 minutes, that's ideal. And then this was level 1 evidence that was developed through systematic review and meta-analysis of many different testing centers and lots of data. And there 4 studies were included within the meta-analysis, and they identified significant survival benefit in patients who received pre-hospital versus none. There was about 2,000 total patients. There was a significant reduction in 24 hours mortality. There was no significant difference at 28 to 30 days mortality or of venous thromboembolism. So the conclusion demonstrated that pre-hospital TXA is associated with significant reduction in early mortality in trauma patients. And suspected or confirmed hemorrhage, no increase in the incidence of VTE. So it doesn't cause blood clots. And if it's given early, it improves survival. You could certainly look at this from another perspective and saying like, well, it doesn't seem to have any difference in 28 or 30-day mortality. But the point I think there is that they probably would have died pre-hospital without the intervention. So the 28 to 30 mortality is, I think, you could consider that sort of a multifactorial phenomenon, which with critically injured patients is almost always the case when they die within 30 days. So again, just to reiterate, TXA is a temporizing measure and it is not definitive hemorrhage control. The most critical life-saving measure to be taken in hemorrhagic shock is rapid transport to a level 1 trauma center. This is supported by a lot of evidence. Do not delay transport to gain IV access or to administer TXA. This must be done en route. In general, when we get somebody that's had TXA, that's what we see, and we appreciate that very, very much. I know how difficult that is. I spent some time in ambulances when I was a younger Shurtleff, yeah, it is not an easy job. Early C notification also is critical. That allows us to mobilize blood bank resources, get ready for massive transfusion, personnel and equipment necessary in place to get potentially a REBOA, arterial line catheterization, wide bore access, instruments to do things. Mobilize the OR. So that's just a general kind of broad strokes review of hemorrhagic shock and TXA. I'm going to pause a second here. Are there any questions that someone would like to ask? Let me just take a look. I'll take a look at some of these here. Again, I apologize. I'm not the most tech savvy person in the world. Eric was making fun of me before.
We had 2 questions. I actually got them down for you.
Oh, okay.
The first one was the provider had been instructed to provide TXA in 1,000 mLs of normal saline and run it wide open. What are your thoughts on that?
Well, my thoughts on that are I think we should stick with what the evidence supports. I think if you're getting guidance from OLMC to do that, then follow what that doctor is saying. But in general, avoiding or at least temporizing hypotension in any way possible in these patients is important and critical. It may mean the difference between somebody we can rapidly transfer through the emergency department to somebody who is going to stay there and need a lot of resuscitation, potentially need thoracotomy. I mean, like the consequences of inducing hypotension and unnecessarily are, they can be dire. And so I think that's why the protocol is so clear on that.
Excellent. And as far as TXA being contraindicated for patients under 16, why is that? Does it cause more damage or no change?
I think it's just not well studied. And we try to figure out what's right for adults first, and then there are all sorts of safety measures in terms of doing research on kids that until we have evidence to support its use, it's limited to people over 16. No, it's a good question. I think I could speculate to all sorts of different reasons, but really it's all going to come down to it just hasn't really been studied enough to be approved for use in kids. I mean, I could guess maybe there's an increased risk of clot formation, maybe, but I still, yeah, I'm sorry, I don't want to speculate, but I do know that the evidence doesn't support it because it hasn't been well studied.
Fair enough. Seems to be the consistent theme there.
Yeah.
Also, current non-protocol usages of TXA, atomized for epistaxis, scalp lax, irrigation, or nebulized TXA for EV.
Yeah, I mean, if you have an FDA-approved delivery system that you have a protocol for use and guidelines to use, then by all means. I think intravenous TXA, 1 gram for hemorrhagic shock that's marginally or not well controlled because you can't and because you don't have any means to in the field. I think that's really kind of specifically what we're talking about for this lecture. But again, like if you're using it, it's always with the guidance of the online medical person. So whoever you're talking to here, their guidance is what you should use. Fall back on.
And final one was also for tourniquet conversion for extended scenes and long transports.
Tourniquet conversion. Can they elaborate on that?
I believe swapping out tourniquets and loosening.
Oh, swapping out.
Yeah.
So yeah, we'll talk about that. I would say in general, no. Once it's applied and well applied, leave it on. You have 6 to 8 hours of warm ischemic time for a limb. So the general recommendation from the American College of Surgeons is once it's on, it's effective, don't take it off. In fact, and we'll talk a little bit about it. Was historically there was there was this notion that you should give the limb a drink, let it bleed a little bit more, and then reapply the tourniquet. And I think that's inviting a lot of negative downstream consequences, and that's why we no longer recommend that. Number one being it's more blood loss. Number two being you're pushing that patient even closer to trauma-induced coagulopathy, and taking a situation that's potentially stable and making it unstable. And again, I think a lot of this comes from vascular surgery, but we do operations in patients where they have no blood flow to the limb for extended periods of time. 6 to 8 hours is sort of what we're trained in residency. And it's borne out. I think when you have a patient that's ischemic, even for that period of time, and I know no one's generally transporting that long, hopefully, um, that they probably will require fasciotomies because the reperfusion injury, the muscle swells distal to the injury, or kind of anywhere you had the tourniquet on if you've had it on for that long. But we routinely induce limb ischemia for operations for 3 to 4 hours, sometimes longer in the hospital. So anyway, it's safe, I guess I should say. And what's not safe is to take it off or switch it out.
And this may be part of your next part, but there was a question about best placement for tourniquet, high up versus 2 inches above the wound.
Oh yeah. No, we're gonna talk about that. We'll talk about
Perfect.
that, and I'll explain some of the rationale. So I think, and I apologize. First, I meant to say this before as a disclaimer because Eric wrote this like really exciting lead in for what this lecture is going to be, and it's super dry the first half of it. But there's some interesting pictures and things coming along that hopefully will be a little more exciting. So thanks for kind of bearing with me through the first part of this. But those points are really important in giving the evidence that supports what we do and why we do it, I think helps in the practice of it. I mean, and so without further ado, this
Here comes the
is a
exciting
mangled
part.
lower extremity. Yeah. So I think, this is that motorcycle accident. This is, that shoulder injury when they hit the soft shoulder and they put their foot out, or this is somebody with an extended limb in a front impact MVC. That's where we see this type of injury. And oftentimes, when somebody brings this patient in, they will ask me or who else might be standing there, like, hey, do you think that limb is salvageable? And I just want to say that a plug for our ortho trauma guys, that would be Camuso, Stadler, Blaisdell, and the rest. They can do really amazing things with lower extremity trauma. And even something like this is potentially salvageable. Although this is pretty gnarly. Uh, so I guess what I should say is two things. One, um, you're never write off a limb. I mean, unless you have to amputate that limb in the field with the fellow or with some sort of guidance from us, um, to save the patient's life. Never give up on a limb. Try to get it here. Try to protect it. Do whatever you can to get it here because I think they've got a pretty amazing track record in saving things that don't look salvageable at the outset. Say that, and then secondly, I would say if you are really wanting to know what happened, let your chief know, and then your chief can call me, and I can let you guys know what happened ultimately with the limb because it is such an effort to get this patient to the hospital alive, and I mean I can't like it's impossible to express like the appreciation that we have for what y'all do. Um, and so I just kind of want to be able to let you know in real time that these patients are actually doing okay. Let's see here. Now it's not advancing. Uh-oh. um, Error. Uh-oh. Hang on a second. Maybe I clicked on something. Oh, I did. Totally. Okay. Nope. Hey, Eric, can you tell me what you're seeing?
I see open fractures now.
Okay. I'm gonna see if no, it's not. I'll just have to click on the slides as I go, I guess, because it's not wanting to advance. I don't know what I did. I think I clicked over here and now maybe I go back to presentation, maybe. At any rate. So if you see open fractures, we'll just go there.
Yeah, I see
So
extremity trauma,
I'm sorry.
open fractures. I see extremity trauma, open fractures in the protocol.
Yeah. Okay. Great. So the definition of an open fracture is fracture with extensive tissue damage, wound, invisible bone. A lot of times, it's like a distal femoral fracture will poke through and then retract back in. So you may see like a puncture wound overlying where that fracture is. I would say when in doubt, those patients should get antibiotics in the field en route. If you have any, if you suspect an open fracture, then those patients should get antibiotics. Um, Assessing for other life-threatening injuries is the first step. At the EMT level, if they're otherwise stable, gross contamination should be removed if possible. You can use sterile saline to do this. You can cover with a moist, sterile dressing. Any larger wounds and stuff. That's generally what to do if they're hemostatic, not bleeding. And then splint in position, and if possible, comfort. And then again, if you're most of you, I think, are ALS in the field already, but if not, pain control is going to be important for these folks. And then, again, if you're suspecting an open fracture, if you see exposed bone, early antibiotics we know can help with limb salvage and post-injury infections. If you're advanced EMT, this patient you would need to establish the IV to give the antibiotics and volume if they're shock at all. Oops. Um, and so this is ceftriaxone for patients 12 or older. At the paramedic level, you're going to administer 2 grams IV in NS or D5W. If they're less than 12, they'll get a lower dose of 75 mg per kg. It's contraindications a patient with history of anaphylaxis to penicillins or cephalosporins. So asking about allergies is always important part of your assessment. Um, Let the receiving hospital know you're giving antibiotics, and we'll ask anyway too when you get here. Um, and really, what's critical is that it's as like TXA as close to injury as possible, um, in terms of maximizing the the effects. So some pitfalls in extremity trauma. Again, if we fail to give timely antibiotics, there can be downstream consequences, and those are actually infections that in osteomyelitis that can't be cleared are probably the main cause of needing an amputation downstream once we get them stabilized, because there's all sorts of ways to reconstruct these folks, but if they have a deep-seated bone infection, then ultimately they may proceed to amputation. I actually have one patient like that where they were able to stabilize everything. We got the belly stuff controlled. The ortho rebuilt his leg, and then he just had this persistent bone infection that could not be cleared no matter what we threw at it. So ultimately, he needed below the knee amputation. But so and really like putting that all at saying that, oh, it was because like maybe the antibiotics weren't given early enough is probably not really the truth. I think it can help, but it's not necessarily the make or break. It's just can contribute to a downstream issue. Sometimes limbs truly aren't salvageable, and that I think was this patient's case anyway. Um, let's see, going back. See, yeah, here we go. Okay. So, hemorrhage from long fractures can be significant. Femoral fractures in particular can often result in significant blood loss. In fact, enough to make somebody unstable. You can hide a couple of liters in your thigh pretty easily. In fact, I've got a patient picture coming up that's exactly what happened with this gentleman. Um, and again, if you have enough, if you have a couple liters of blood loss, if you remember back to the hemorrhagic shock slide, that's enough to induce class 4 shock, right? That's 2 liters. That's 1/3 the total blood volume circulating, and you're going to see hypotension, tachycardia, and all sorts of other all the other changes associated with shock. So those folks for sure, you're getting a tourniquet on, and you're resuscitating appropriately to give you TXA. So really, but again, this is from the American College of Surgeons, but delayed transfer to a trauma center is really the number one pitfall. And the sooner they're here, the sooner we can stabilize what's going on. Transferring patients with vascular injury and a concomitant fracture to a trauma center with vascular and orthopedic surgery capabilities are what is life-saving and limb-saving. Bilateral femur fractures can result in significantly increased risk of complications and death because, enough energy to do that to somebody, they've got lots of other associated injuries as well. And you can, if you have bilateral bad fractures, you can lose about, up to 4 liters just in the thigh compartment itself bilaterally. So that's enough to cause someone to arrest. But the other part of this though is it's not subtle. Like, if you have bilateral femur fractures and somebody's in shock, like, it's you know what you're looking at. So some basic stepwise approach to managing extremity trauma. Manual pressure first, again, is always the first thing, although a wound this size, that might be difficult. You apply a pressure dressing. So it's sort of a step up fashion to a bleeding hemorrhage. Pressure dressing applied. You put a stack of gauze, circumferential elastic bandage, and I see a lot of these coming in, and they all look great. Most of them are effective. I think a lot of folks are using sterile gauze, Coban, and for a lot of what we see in terms of our extremity injuries, that's effective. In general, that will probably control like a radial artery injury, which we see a fair amount of here at the wrist. And they may not even need the tourniquet, although, it's obviously safer to have that as well if you have something like that going on. If the bleeding persists after a pressure dressing, then you move up to manual pressure to the artery proximal to the injury. This is from the advanced trauma life support training for residents. But y'all know kind of where to find the artery with femoral or brachial for a limb. And so that's something that we would want you to do as well. And then if the bleeding continues, you should apply a tourniquet. And I would say even if it stops with manual pressure to the artery proximal injury, then a tourniquet's going to work for you too. Manual tourniquet and a properly applied tourniquet includes arterial inflow, which is what you need, because if you just include the venous outflow, you can make hemorrhage worse, which makes sense. If you're compromising the veins for things to return and you're still pouring blood into there, then the bleeding can't stop. But these are just this is another effective method with something where you don't see obvious arterial bleeding kind of spurting out of the wound. And it's sort of just welling up in there because you have multiple small vessels that are all bleeding, briskly. This is from the Stop the Bleed instruction manual, and it's important to get the clothing out of the way so you can see the extent of the wound, and then removing the excess pooled blood out of the wound first is actually really important, because then you can't because then you're exposing the bleeding surface to either hemostatic gauze like combat gauze or some other hemostatic gauze. Then you're actually exposing the whole surface to that. It allows you to pack circumferentially and really fill the space, which is the goal of wound packing. And the clot is not compressible, so it'll sit against the bleeding surface and the bleeding will continue underneath it, if that makes sense. So with gloved hands, get the blood out of there and then get the packing into the wound. And again, it's also important, like once you get that clot out of there, you'll be able to see the site of most active bleeding. And so that's the, that's kind of the way to approach like a big open wound, like in the picture. If you have hemostatic dressing, that's probably the best thing to use, like quick clot, combat gauze. And I think most ambulances are carrying this stuff. I also think that just a plug to have some of this stuff in your car with you at all times, because it seems like, you get called to all these things when they happen, but a lot of times, and why the American College is so committed to trying to train out into the communities, that a lot of times when someone has life-threatening hemorrhage in the field, a first responder is going to be the one that actually takes effective action early before you all even get there. And so I tend to forget that I also, like, I'm outside the hospital, I'm a first responder, you know and and it's easy to kind of relax and move out of that. But it is helpful to have hemostatic control agents with you. Um, but you can really use anything to stop the bleeding. It's more important to stop the bleed than what you use. But the goal is really to fill the void and apply pressure circumferentially. So you go down and you pack out to in, so that as you're coming up into the wound to the surface, you've got really good pressure being applied radially in the void of a soft tissue defect. This was one of our patients. This is Morel Lavallée lesion. This patient was run over by a dump truck. And you can see all this soft tissue injury was underneath. And what a Morel Lavallée lesion is when the fascia, the connective tissue of the soft tissue that's attached to the muscle, shears off and tears all these blood vessels here. There was no large arterial injury here, but this patient was unstable and this is just kind of to illustrate how much space can be created and how much blood loss you can have just from the muscle and the smaller vessels that connect to the subcutaneous tissue outside the muscle. But this is the quadriceps here. This is a muscle defect, and then this is all just flapped skin and soft tissue. This patient required 3 operations after this initial one where hemorrhage control was obtained to slowly take back the tissue as it died till we got to a point where it stopped demarcating. And that's pretty typical for these big injuries. But just kind of so you know what happens afterwards with something like this. It takes a lot of of work and resources to get them to the point where then they're ready to be grafted. But these are general tourniquet notes for use that I think are helpful, and probably gets to that question that we had before. Our recommendation for the American College of Surgeons is to apply your initial tourniquet 2 to 3 inches proximal to the injury. So if it's if it's at the mid shin, you would apply that tourniquet just distal to the knee. You don't want to apply over a joint. If it's at the wrist, you can effectively compromise blood flow and stop blood flow if you apply the tourniquet here. I think, and we did this in our Stop the Bleed course last night, and people when you apply, and you can do this with training tourniquets at your station or whatever, see what that does, because not everyone needs a high and tight tourniquet. I know that that's what the training is, but you should always try to do it closer to the injury first, because most of the time it will be effective. And in that case, you're limiting how much tissue is not receiving blood flow of oxygenated blood. You're limiting tissue ischemia, right? If I apply a tourniquet here, it's only everything below my hand where that has no blood flow. If I apply a tourniquet all the way up here, then the entire arm is ischemic tissue, and that can worsen rhabdomyolysis, that can worsen trauma-induced coagulopathy. All of these things have consequences. So our recommendation is to try your first tourniquet is within 2 to 3 inches of the wound itself. if you have to go, if say the injury is here and you have to go above the elbow joint, um, again, I'm just seeing what I think I'm seeing what Kate's saying here. Hold on a sec. Let's see. Kate says, "Hey Kate, would you mind just saying what you just wrote?"
Yeah, so we teach high and tight mostly for like those of us that are working in a tactical setting, or if we're on a rescue task force going into an active shooter in a warm zone, we may not
Right,
have time to like delve exactly where in the limb that this pool of blood's coming from. So we'll
yeah,
start by just putting that tourniquet on high and tight, and then hopefully, get them
right.
extricated out.
No, that's so
Yep.
yeah, there's a little bit of nuance to that, but if there's not an active shooter, then
Then
that's I think the one case where you go quick and you get right. But when the scene is safe, closer to the wound is better for the patient. So that's but that is I understand that that's kind of why the I understand why that is
yeah.
the
And so
protocol. It makes sense.
that's what you'll see, like the police, when they do
Right.
a lot of the tourniquets pre-hospitally, and that's why they're
Right.
coming in. But yes, for this general audience, like you said, exactly what's on your slide.
Yeah. And then and I think everyone listening probably understands the difference of those two scenarios. If the again and the nice thing about the lower tourniquet is if it stops the bleeding, great, you've limited tissue ischemia to the limb. If it doesn't, you still have the proximal option. You can put the high and tight tourniquet on. And if both tourniquets fail, then you're reverting back to two-handed manual pressure, hemostatic gauze, and you know, just a plug for manual pressure. You can stop the aorta from bleeding with a couple of fingers. Obviously, that's harder to do in a large open wound, like the one in the picture, but kind of never kind of underestimate the effectiveness of that if you can get the wound really well packed or wrapped. Um, those sometimes using things in combination or going back through the algorithm as you're dealing with it can be the difference between control and not. Some of the mistakes, not using a tourniquet or waiting too long to apply it. That's pretty self-explanatory. And then tight enough to stop the bleeding. It hurts the patient. It doesn't get applied tight enough. The bleeding continues, and then you haven't really addressed what's going on. Not using a second tourniquet. So a lot of times the first one gets tried, and there isn't an attempt for the second or to really compress the wound. And then periodically loosening the tourniquet again, we recommend against that. I suppose if you had like a 12-hour transport, we would have a discussion over the phone about what to do with the limb. But in general, like I said, within 6 to 8 hours, you're not going to induce any harm with a tourniquet, and in general, they should be left on. And again, a paramedic or a physician are the ones to be qualified to take one off. And then crush injury. This is just a kind of small part, and I realize I'm going over. I'm sorry. I'm almost there. In terms of crush injury, the concern can be arrhythmias induced by rhabdomyolysis, where you have muscle cell breakdown from the extent of the injured muscle, and they're releasing potassium into the bloodstream that can cause hyperkalemia and arrhythmias. And so the recommendation, if they have a significant crush injury, sodium bicarbonate, 1 milliequivalent per kilo, max 50 over 5 minutes, is the recommendation that can kind of attenuate some of the acidosis that comes with muscle cell breakdown and can also contribute to cardiac arrhythmias. And then also, these are patients that need volume, and they need, so the adults, and we'd use NS because it doesn't contain more potassium in these patients. So significant crush injury, it's important to kind of think about rhabdo, think about acidosis, think about T wave changes and due to hyperkalemia, and and then combining bicarb and NS to help flush some of that some of those substances out. It's interesting. It's always interesting, like looking through your protocols and thinking about this, because we have really the luxury of all the labs. We know what's going on. We know what they need treatment for, and here it's just like it's the beauty of pre-hospital life support is that it's all based on physical exam and like reasoning in the field and really incomplete information. I mean, as trauma surgeons, we pride ourselves on being able to make decisions on incomplete information, but like it's really kind of pales in comparison to what you all do. So again, just another big appreciation to y'all. And then one last pearl, suspension trauma is the same. So like prolonged suspension in an overturned vehicle or something like that. We actually had a patient that was wedged in a chimney that came to us that was there for several hours, and that patient had some of the most profound rhabdomyolysis I've ever seen. I mean, we were managing that for probably a week and a half before his creatine kinase came below 20,000. But ultimately, we preserved his kidneys, and really what it took was bicarb and NS. So the treatment is straightforward. But if they don't get it in timely fashion, you can lose kidneys. So that is finally the end. Thank you all for listening and listening a little bit later. Are there any other questions I can answer?
I think that was all of them. So thank you for your time.
Thank you all so much. Swans Island, that's awesome. I love it up there. Anyway, appreciate you all. Thank you so much. We'll see you in the trauma bay. I'll probably see you at your agency at some point. Oh, someone's asking about bolusing patients prior to extrication. I mean, if you can get an IV in, yeah, but awesome. Honestly, again, like the think about it as anything that delays scene time or prolongs scene time in somebody who's critically injured probably should wait for the rig, if that makes sense. The focus should be how do I get them to the trauma center as rapidly as possible, because there isn't much that can be done in the field if someone has life-threatening hemorrhage other than the things we've talked about. So that's really the number one kind of thrust is like get them to the hospital as fast as you can.
All right.
I will come visit Swansea. I love it up there. We were just there a couple summers ago. It's such a beautiful place. Anyway, yeah, thank you all again.
Thank you all. Have a great day.